in medically complex patients with cardiovascular disease. This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions. The two powerhouses are the Healthcare Systems Research Network and the Claude D. Pepper Older Americans Independent Centers, or Pepper Centers. The Aging Initiative is led by Dr. Jerry Gurwitz at the University of Massachusetts and Myers Primary Care Institute, along with co-PIs Elise Adams and Jay Magaziner. My name is Heather Whitson. I'm an Associate Professor of Medicine and Ophthalmology and the Deputy Director of the Duke Aging Center, and I'm part of the Aging Initiative Dissemination Workgroup, co-led by myself and Leah Hanson at HealthPartners. Before we get started, I need to cover a few of the technical details for today. Due to the number of registrants, we have placed phone lines on mute to reduce audio feedback. So unless you are logged in as a host or a panelist, your line is muted. However, we welcome and encourage audience participation using the Q&A and chat features of the webinar software. If you are in your Cisco webinar portal, look at the row of circles across the bottom center of the screen, and you can click on the chat bubble icon until it is highlighted blue. If you have questions for our speakers, please click on the Q&A tab on the right side of the screen and type into the Q&A box. Leah and I will keep an eye out for those types of questions under the Q&A icon, and as time permits, we will read the questions for our speakers at the very end of the presentations. If you have a technical or logistical question, we ask that you submit those using the chat box. You'll see that above the Q&A box. Please make sure that you're identified by either your name or your participant ID so that the webinar hosts will be able to troubleshoot any problem that you're having with audio or other issues. With the chat function, you can choose whether you'd like your comment to be visible to all participants, or you can choose to send a question only to the hosts. We want to extend a huge thanks to those hosts, Catherine Anzalone and Chris Delude at the Myers Primary Care Institute. They do amazing work behind the scenes to make these webinars possible. They will be monitoring the chat functions today to help with any of the technical troubleshooting. And now I'd like to introduce our first speaker. Our first speaker is Dr. Amgad Mentias. He graduated from Ain Shams University Medical School in Cairo, Egypt in 2009. He did his residency for 3 years in Egypt, but then decided to pursue graduate medical training and education in the U.S. He did his internal medicine residency at Cleveland Clinic in Cleveland, Ohio, then moved to Iowa City to do his cardiology fellowship at the University of Iowa. He is currently in his second year of training and is also pursuing a master's degree in clinical investigation at the University of Iowa College of Public Health. He's interested in joining a clinical electrophysiology fellowship after he is done with his training at the University of Iowa. He's also very interested in research and sees himself as an academic cardiology career in the future. Dr. Mentias, it's all yours.
Okay, hi. Good afternoon, everyone. Thank you for coming to this event. Let me share my screen. I'm sorry. Okay, is this, everybody can see the screen, the PowerPoint presentation?
Yes, we can see it.
Okay, thank you. So our talk today is about a project that Dr. Sarrazin and myself, we did at the University of Iowa. It's titled Comparative Effectiveness of Oral Anticoagulants in Patients with Atrial Fibrillation and Multiple Chronic Conditions. And we used the Medicare analysis for that. So this paper was recently published, and we were invited to present the work. So there are no relevant financial disclosures. Dr. Sarrazin is supported by a fund from the Agency for Healthcare Research and Quality. So the background, atrial fibrillation affects 3 million adults in the United States, and it's actually projected to increase in prevalence more and more as the population ages. AFib increases the stroke risk by 3 to 5-fold by left atrial thrombus formation, and blood thinners or anticoagulation are the treatment of choice to reduce the risk of stroke in these patients. Now, several agents have been available for patients with non-valvular atrial fibrillation. Warfarin, which is a decades-old medication we have the most experience with. However, it comes with some caveats like measuring INR regularly and affected by food intake and medication intake. And then the newer direct oral anticoagulants, 4 of them are approved in the United States and we're used right now: dabigatran, apixaban, and rivaroxaban, and edoxaban. So the last 3 are factor 10A inhibitors, while dabigatran is factor 2 inhibitor. However, blood thinning medication comes with the price of increased risk of bleeding. So as atrial fibrillation increases with aging, and as elderly people are known to actually suffer from multiple comorbid conditions the older they are, and unfortunately both age and comorbidities are risk factor for stroke in AFib patients and also their risk for bleeding. So this creates a dilemma where you always have to balance or outweigh the benefits you're offering to the patient with blood thinning medication to protect him from stroke against the harms that he might experience and go through if he suffered a major bleeding, depending on his risk. So as a background, there is a study of about 300,000 AFib patients and 500,000 control, and it showed that the prevalence of any concomitant disease was about 70% in AFib patients compared to age-sex matched cohort, which was only 28%. And concomitant diseases included stroke, renal failure, COPD, lung disease, hypertension, diabetes, and neoplasms. So AFib population at the same age are just sicker and have multiple comorbidities than their similar age people without AFib. And another study from UK, AFib with more than 4 comorbidities had 6-fold higher risk of mortality compared to participants who had no other long-term conditions. And risk of mortality actually was significantly increased with presence of heart failure with AFib, or COPD with AFib, or osteoporosis with AFib. So in atrial fibrillation patients who are older than 75 years old, more than 50% of them are not prescribed any anticoagulation, despite having a very high risk of stroke by the very commonly used score, CHA2DS2-VASc score. We'll come to the CHA2DS2-VASc score when we talk about the methods in our paper, but it's a score that gives the patient a score from 0 to 9 to assess how much stroke risk he has in every year. It's an annualized risk. So despite having a high risk of stroke, more than 50% of these elderly people are not prescribed anticoagulation. And frailty is an important factor that actually sways physicians from prescribing anticoagulation to these patients, either because of recurrent falls or because the cognitive impairment. And cognitive impairment and dementia is especially important in warfarin because it affects the quality of anticoagulation itself, because these people usually do not keep on with their measurements of INR, and they don't adjust those appropriately, so they are at risk of over-treated and bleeding risk, and also under-treatment and stroke risk. So a lot of physicians don't prescribe these patients warfarin to start with or any anticoagulation. So in 2 studies from France and from US, even after the direct oral anticoagulants were approved and were in AFib patients, still they are prescribed to younger patients and to healthier patients compared to warfarin. And this is probably because physicians feel they have the most experience with warfarin for years, and DOACs are just new in the market, and we don't yet know their exact outcomes in very elderly people and people with multiple comorbid conditions. So despite being the more sick population and the highest risk in stroke and bleeding, we're prescribing warfarin DOACs, and nobody knows which is better in this population. The same paper showed that direct oral anticoagulants are less likely to be prescribed in patients with both higher bleeding risk and higher stroke risk. It's actually warfarin, which is usually prescribed, if it is prescribed in these patients, if any blood thinning medication is prescribed. And the problem is that the 2 landmark trials that actually resulted in approval of rivaroxaban and dabigatran in the United States by FDA for non-valvular AFib stroke risk reduction, as a general problem in all controlled trials, they are limited in generalizability and application to the general population or real-world patients. In the Rocket AFib trial, less than 15% of the study participants had any score more than 5 or more. So most of them were low to intermediate risk. And in the RELY trial, less than a third of the study actually had a CHAD score more than 3. So again, it was mostly low risk to intermediate risk patients in stroke and bleeding. So our aim of the study was to compare the effectiveness of warfarin, rivaroxaban, and dabigatran in stroke prevention in these elderly high-risk patients with AFib who have low, moderate, and high levels of comorbidity burdens, and to compare the safety of warfarin and these medications regarding bleeding, major bleeding, and intracranial bleeding, and GI bleeding in these people with low and moderate and high levels of comorbidity, and to use a real-world data for that. So we used the Medicare inpatient carrier data for that, and Dr. Sarrazin is my mentor, and she's the senior and corresponding author. She's an associate professor in the internal medicine department at the University of Iowa. She's gonna present the methods for the paper. So I'm gonna pass the screen to her, or the presentation to her.
Okay, can you hear me okay?
Yes, may I introduce you first?
Oh, sure.
Dr. Vaughan-Sarrazin, okay. So you're about to hear from Dr. Vaughan-Sarrazin, an associate professor in the Department of Internal Medicine at the University of Iowa College of Medicine. Dr. Sarrazin has a PhD in health management and policy and has served as a principal investigator on multiple grants from the VA HSR&D, AHRQ, and National Institutes of Health. She's also a core investigator at the VA Center for Access and Delivery Research and Evaluation, or CADRE, at the Iowa City VA Medical Center, where she directs the Data Analysis and Biostatistics Core. Most of Dr. Sarrazin's research has used large databases such as Medicare and Veterans Administration and clinical data sources to investigate issues related to effectiveness, safety, and equity of treatment and outcomes of cardiovascular disease. Her investigations into the use of anticoagulation therapy for stroke prevention and atrial fibrillation began in 2012 through a K-18 mid-career award from AHRQ. The work presented here was funded by an R01 from AHRQ to investigate the use of non-vitamin K oral anticoagulants in elderly patients with multiple chronic conditions. Thank you for being with us today, Dr. Vaughan-Sarrazin, and the floor is yours.
Okay.
Thanks. And Dr. Vaughan-Sarrazin? I think you may be on mute.
Can you hear me?
Now I can hear you.
Oh, okay.
Okay.
So Amgad, I don't think I'm able to share my screen. So could you forward the screen as we go through it?
Yes, sure. Yes, Dr. Sarrazin.
Yes. Okay. Okay. So anyway, so as Amgad mentioned, you can hear me okay?
Yes, we can hear you.
Okay. All right. So as Amgad mentioned, the data we used was the Medicare data. We had data from years 2010 to 2013, and that included Medicare inpatient, carrier, and pharmacy Part D claims. We identified patients with newly diagnosed AFib, and this was defined to include patients age 66 and older to ensure that they had at least 1 year of Medicare eligibility. We defined AFib using ICD-9 code 427.31 on prior claims. And we defined new AF as either one inpatient or two outpatient claims within 90 days of each other, and no prior AF, no prior claim with an AF diagnosis in the prior 12 months. So from the patients identified with newly diagnosed AF, we then identified patients who were initiated on dabigatran of 150 milligrams twice daily, rivaroxaban 20 milligrams once daily, or warfarin within 90 days of the AF diagnosis. We didn't look at the lower doses of these drugs, partly because at the time there were substantially fewer patients taking the lower doses. We also were not able to look at apixaban, again, due to the time frame of our data. Apixaban was still fairly new and not used substantially at that time. I should also note that we limited our patients to those who were anticoagulant naive. In other words, they had not used any oral anticoagulant during the prior 12 months. So we were looking at new users of anticoagulation. We excluded patients who were enrolled in a Medicare managed care plan during the observation period, and that's because typically Medicare patients enrolled in Medicare managed care, their claims data are incomplete. And we also excluded patients not enrolled in a Part D drug prescription plan. So then anticoagulant type was defined by the first anticoagulant received after AF diagnosis. Okay, our primary outcomes included the primary diagnosis on acute inpatient claims as defined by ICD-9 codes, and so we were looking at acute admissions for ischemic stroke and acute admissions for major bleeding events, and that our primary outcome included any major bleeding event. Secondary outcomes included gastrointestinal bleeding, non-GI major hemorrhage, which included intracranial hemorrhage, acute myocardial infarction, and then we also looked at all-cause mortality using dates of death available on the CMS enrollment files. So we had three different measures of multi-comorbidity. And so I'll briefly explain the three measures. The first measure we used was the CHADS-2 VASC stroke risk score. And as you know, many people are already familiar with this score. But basically, it has been incorporated into many clinical guidelines for treatment of AFib to guide the decision to anticoagulate patients. And it incorporates these conditions that are listed here on the screen. Patients receive 1 point if they have congestive heart failure, hypertension, age 65 to 74, diabetes, vascular disease, and female gender. And patients receive 2 points if they have a history of stroke or age greater than or equal to 75 years. And the presence of these various comorbid conditions was defined by searching through the claims incurred during the 12 months prior to initiating the anticoagulant. The CHADS-2 VASC ranges from 0 to 9. I should note that the minimum score in our study was 1 because all of our patients were age 65 and older. And actually, the vast majority had scores of 2 or higher. We then created 3 groups of the CHADS-2 VASC stroke risk score, categorized as low comorbidity, defined as a score of 1 to 3, moderate comorbidity, defined as scores of 4 to 5, and then high comorbidity, defined as scores of 6 or more. Second score was a had-bled bleeding risk score, and this again has been incorporated into some clinical guidelines to assess the patient's risk of bleeding. And it includes hypertension, prior stroke, a history or predisposition towards bleeding, age greater than 65, alcohol or drug use that increases bleeding risk. And the drugs that we included there were things like NSAIDs, antiplatelets. I think there might have been a couple others. History of liver and renal disease. And then also, usually the score would also include an indicator for whether the patient has a history of label international normalized ratio while they're on warfarin. This wasn't relevant to our study since all patients in our study were anticoagulant naive. And this again is based on these scores. Again, are based on the diagnoses present in the patient's claims during the 12 months prior to initiating the anticoagulant. As with the CHADS-2 VASC, the score ranges from 0 to 9, although the minimum score in our study was 1 because all our patients are age 65 and older. And then, as with CHAS-2-VASc, we separated patients into low, moderate, and high levels of morbidity based on the HAS-split. And then our last score is what I call the Gagne Comorbidity Score. This is a score created by Joshua Gagne, and it was published in 2011. And it was developed for use in a more general population. It basically was developed in a population of patients enrolled in Medicare with drug coverage. And the purpose of the score was to represent all-cause mortality risk. So it's really a more general score of patient sort of morbidity, health status, and mortality risk. And that was one of the reasons that we wanted to include it. And it includes these conditions listed here. There's 19 different conditions. They're scored differently. So renal disease might, for example, might have a score of 3, and weight loss might have a score of 1. So they're scored differently, but summed into a single score. And then, as with the other scores, we distinguished patients. We categorized patients according to the Gagne Comorbidity Score as having low, moderate, and high risk. So our method, our basic statistical approach was, first of all, as discussed, we divided patients into low, moderate, and high MCC categories, and we did this for each of the 3 comorbidity scores. And then we used a 3-way propensity matching algorithm to match patients so that to create groups of patients who were plausible candidates for any given drug. And essentially, the way the 3-way propensity score matching works is that we are attempting to minimize the observed difference between any trio of patients. So between patients taking rivaroxaban or dabigatran or warfarin, we want to identify those patients that have common characteristics across all 3 drugs, and that's kind of depicted in the picture here, where we're looking for patients who are plausible candidates for any 3 of the drugs. This is a little different than in traditional propensity matching. Usually we're doing a 2-way match where we want to match, to identify patients who are similar and taking rivaroxaban or warfarin, or rivaroxaban versus dabigatran. And this way we're doing a 3-way matching where we want a set of 3 patients to have roughly similar characteristics. After we did the propensity matching, we evaluated the standardized differences between groups to confirm that we had adequate balance among the patient covariates. So the propensity matching, we conducted actually 9 different propensity matching algorithms because we matched patients within morbidity level for the 3 separate scores. So that's 3 scores, 3 levels per score. So that was actually 9 different matching algorithms. And we actually evaluated standardized differences between the drugs for each of these 9 different matching algorithms to confirm that we had adequate covariate balance. And then we conducted, we analyzed the matched samples using Cox proportional hazards regression to evaluate time to our key outcomes, time, in other words, time to ischemic stroke, time to major bleeding, time to GI hemorrhage, and so on. Patients were censored, and the censoring, as we followed patients through time, and the censoring events included the end of our observation period, which was December 31st, 2013, the cessation of the initial anticoagulant, which was defined as the last fill date plus the days supplied at that last date. And then also for analysis of stroke and bleeding, we censored patients if they died. Okay, and I think I'll turn it back over to Amgad.
Yes, can you hear me? Hi, can you hear me?
Yes, we can hear you. We can hear you.
Okay. Thank you so much, Dr. Sarrazin. So results. So table 1 shows the characteristics of the population that was included in our study So total 22,000 were taking dabigatran, and about 24,000 were taking, 20,000 were taking rivaroxaban, and about 100,000 was taking warfarin. And as you can see, as this table shows, warfarin patients were elderly than DOACs patients. They were more likely to be females. Females are under-prescribed DOACs, and also they were having more comorbid conditions like we see here. So heart failure, 37% in warfarin, but 24% in the other two groups. Same thing for diabetes and hypertension, where the numbers were higher in the warfarin group. Renal disease, 22% compared to 8 and 9%. So the warfarin population was sicker, and when we discuss the background, we know that this is probably what's happening in the real world, that sicker patients and older patients are prescribed warfarin and not DOACs just because we don't know how they do in these patients. So this is the proportion of the study that's actually high risk by the three different scores. So we had about 36% in the warfarin, about 23% in the other two groups with a high stroke risk with the CHA2DS2-VASc score, and we have more than 15% to 20% of the population had high bleeding risk with Hajduk score, and we had about 20 to 30% of them in the high Gagny comorbidity score for all-cause mortality. So it was a big proportion of our patients were actually high-risk patients with high multimorbidity burden in them. So this is the match analysis after we did the three-way propensity match score. And our first outcome here is ischemic stroke after matching, and you can see that there is no significant difference when you compare pairwise comparison between dabigatran and warfarin, rivaroxaban and warfarin, and then rivaroxaban and dabigatran. All three of them are similarly effective in preventing stroke. And the same thing we found for myocardial infarction. It's not shown here, but also MI. There was no difference in MI, which people consider a thrombotic or an embolic complication in AFib patients, can happen with both mechanisms. So it's a part of efficacy, and so the three of them were similarly efficient and to reduce the stroke risk and MI risk between patients with low, moderate, and high stroke risk and multimorbidity burden. And then the second outcome of major hemorrhage, as you can see, we're circling here the people with Hajduk score. You can see that rivaroxaban were actually associated with higher bleeding risk compared to dabigatran in patients with the three, at least with the moderate and the high level of risk with Hajduk score. And also rivaroxaban, there was no difference between warfarin and dabigatran in the high-risk patients. And then with the other scores, also with the CHA2DS2-VASc and Gagny score, rivaroxaban still performed worse than warfarin, than dabigatran, and was associated with higher risk of major hemorrhage. Our next outcome is the GI hemorrhage, and again, circling the Hajduk score, you can see that rivaroxaban did worse than warfarin and also did worse than dabigatran in patients with moderate to high risk. And this was also true comparing rivaroxaban to warfarin when we used CHA2DS2-VASc and Gagny as our measure of multi-comorbidity burden. So overall, rivaroxaban did worse than the other two agents in major bleeding and also in GI bleeding, while warfarin and dabigatran did not have a significant difference. So when we come to the last outcome, which was all-cause mortality, overall, rivaroxaban and dabigatran, there was no difference between them in all-cause mortality, but both of them offered an advantage over warfarin in all-cause mortality when you look at the comorbidity score or comorbidity burden by the three measures, Hajduk and CHA2DS2-VASc and Gagny. So in the high-risk people, in each of these scores, dabigatran did better than warfarin, and also rivaroxaban did better than warfarin. So to conclude, our findings show that rivaroxaban, dabigatran, and warfarin are actually similarly effective for stroke prevention in AFib patients with multiple chronic conditions. However, dabigatran use is probably associated with lower bleeding risk than rivaroxaban, and it's driven mainly by GI bleed, which is higher in the rivaroxaban group. And rivaroxaban is associated with higher bleeding than warfarin in the high-risk patients. On the other hand, both DOACs, rivaroxaban, and dabigatran were associated with lower all-cause mortality compared to warfarin, regardless of the level of comorbidity, low or mediate or high. So there are some limitations in our study. Of course, there is some possible residual confounding from unmeasured factors. When you do propensity matching, you do adjust for all the measured confounders, and we did adjust for multiple variables, at least 20 or 30, but still if there is an unmeasured factor, it will not be adjusted. So there is possible residual confounding. However, when you read our paper, we did a sensitivity analysis when we tried to see if there is an unmeasured factor, how much should it be more prevalent in one group than the other to explain the risk estimate we're seeing. And it was something unrealistic. So it's possibly, if there is a partial confounding or unmeasured confounding, probably it doesn't explain the whole risk difference that we saw. Also, all of our patients were older than 65 years, which actually might limit the reliability of our findings to younger patients. We also lacked information on quality of anticoagulation in the warfarin patients, INR levels, and time in therapeutic range. You need INR to be between 2 and 3 to have a meaningful anticoagulation. However, you could argue that this is actually a point of strength because we want to see what's happening in the real world, not what's happening in a trial where everything is controlled and you make sure that your patient is following and controlling his INR. However, it's still a limitation in the study. These are the references, and we thank you so much for your attention.
Thank you. Thanks to both of you for outstanding presentations. And I want to remind all of our listeners that if they have questions, to please use the Q&A function, and you can type in your question, and after the next set of presentations, we will field questions at the end. So next, I'm going to introduce Alexander Hajduk, who has had some technical difficulties earlier in the call, but we think we have those ironed out. So, Ali, we will keep our fingers crossed. Ali is an epidemiologist in the section of geriatrics at the Yale School of Medicine. She has a master's in public health from the University of Connecticut, a PhD in clinical and population health research from the University of Massachusetts Medical School, and Dr. Hajduk completed postdoctoral fellowship in geriatric clinical epidemiology at Yale School of Medicine. Her research focuses on geriatric conditions in older adults with cardiovascular disease. She has studied the impacts of physical and cognitive impairment as well as multiple chronic conditions on outcomes in older adults with acute coronary syndrome, heart failure, and arrhythmias. She has a Career Development Award from the American Heart Association and has participated in 2 pilot projects funded by the Aging Initiative. Dr. Hajduk, hopefully your audio is working.
Hi there, can you hear me?
Yes, we sure can.
Wonderful. Thank you so much, Heather, and thank you to Dr. Mentias and Vaughan-Sarrazin for their wonderful presentation. I was actually alerted to your paper a few months ago by Jerry Gurwitz, and he said, you know, what a wonderful confluence of projects coming together if you could find a way to co-present on these 2 topics. So I really thank you both for presenting today with us. I'm actually going to start us off by having Greg Ouellet, the junior and co-PI of the pilot project, start us off with the introduction. So Greg, can you unmute yourself? Let's see if we could hear you.
All right, I'm unmuted. Can you hear me?
Yes.
All right, perfect. All right. Let me see if I can share my screen.
While you're working on sharing, while they're helping you with that, Greg, I'll go ahead and introduce you. And in the background, they can give you the ability to do that.
Thank you.
Sure. Dr. Ouellet is an instructor in the section of geriatrics at Yale School of Medicine. He received his medical degree from the University of Rochester and did his internal medicine residency and geriatric medicine fellowship at Yale. He subsequently completed the Yale postdoctoral fellowship in geriatric clinical epidemiology and concomitantly received a master's in health science. His research focuses on complex clinical decision-making in older adults with multiple chronic conditions with a special focus on cardiovascular disease. And hopefully now you can share your screen.
All right. It doesn't look like it. It looks like it's still grayed out at the moment, but if we want to go back to Ali, I can certainly talk along if she's willing to scroll through as I talk.
Absolutely. Let me try and reshare my screen. Oh, the joys of technology. How's that looking?
Perfect.
okay. So, Greg, just let me know when you want me to advance.
Sure. Okay. So today we're going to talk a little bit about a project that we did evaluating the benefits and harms of triple antithrombotic therapy in medically complex older adults with AMI, or acute myocardial infarction, and atrial fibrillation. So before we advance, I just want to give a quick anecdote that tells us a little bit about how we came to do this project. So it's actually really apropos that I'm on service on our acute care for the elders unit at Yale, and I was actually on this unit as a resident when I saw a patient who really stood out to me and really informed the question that drove this study. So I saw a patient that we'll call Mr. S, who was in his late 80s, who had recently had a heart attack and had long-standing atrial fibrillation. And he had been on anticoagulation for several years. And recently, when he had this heart attack, he had had a stent placed and was on both aspirin as well as another antiplatelet agent. So he was on clopidogrel. And the time that I took care of him, he had come in for the third time after this heart attack where he was having severe bleeding episodes. And it was still within a couple of months out from his stenting, and he had multiple bouts of urinary bleeding. And so at that time, which was 2013, we were really struggling to figure out how do we balance the potential benefits and harms for this man. And that was a story that had stuck with me for quite a while. And then during my residency and fellowship, I had the opportunity to work with Ali on Silver AMI, which is a cohort study of older adults with myocardial infarction. And we thought that this was a great opportunity to really think about answering some of the questions related to treating patients with an anticoagulant and multiple antiplatelet agents at the same time. So with that, Ali, if you can forward us to the next slide. All right. So just a little bit of background about atrial fibrillation in the setting of a myocardial infarction in terms of its comorbidity status. So most patients with AMI don't have atrial fibrillation, but up to 20% either have pre-existing or have new atrial fibrillation in the setting of an acute myocardial infarction. So it's not really a trivial number at all, and this certainly is actually larger in older adults that have an acute myocardial infarction. And why is this important? Well, one, we know that it predicts worse outcomes for AMI survivors. So there's more hospital readmissions, higher rates of stroke, and higher rates of death. So what ends up happening for these patients? So most diseases currently treated, most physicians will rely on disease-based guidelines. And so I think that that's likely to be the case for atrial fibrillation and acute myocardial infarction as well. So what do these guidelines say? So AMI guidelines really recommend aspirin and a P2Y12 inhibitor, so for example, clopidogrel, for at least a year, although potentially there could be shortened regimens, but there's not a ton of guidance to really suggest how long, and so it does require some tailoring. In terms of atrial fibrillation, there's recommendation for an oral anticoagulant pretty much indefinitely for the population that we're thinking about. So in our study, we're including most people that are over 75 years old, and so by virtue of their age and their comorbidities, the vast majority of the people in our study are going to have CHA2DS2-VASc scores that warrant an oral anticoagulant. So we see here triple therapy, as we refer to it later, would be the confluence of an oral anticoagulant, aspirin, and an antiplatelet agent. So as our previous presenters have really illustrated, the benefits and harms are pretty similar that we're looking for here, right? So we're still thinking about stroke risk on the benefit side, so improving that risk versus bleeding events. But we're also thinking here, right, these are patients that had acute myocardial infarction, so there's potential for reducing the risk of a recurrent MI. So let's revisit what exactly the guidelines say and think about how do they actually address patients that have comorbid AFib and have had an MI. So we'll take each guideline in turn. And so here is, I believe this is the guideline for looking at coronary artery disease. So this is from that view first. And so as you can see in the second line, keep triple therapy duration as short as possible, and dual therapy only may be considered in select patients, right? So there's attention that this is potentially a problem, but there's not a lot of guidance to tell us which select patients and how do we best stratify and figure out who could benefit and who is more harmed. So then when we think about the atrial fibrillation guidelines in 2014, so we see patients with longstanding AFib or with moderate to high CHA2DS2 VASC scores, efforts should be directed to minimize the duration of triple therapy, and decisions about stent insertion should consider the potential requirement for long-term anticoagulation therapy, right? So again, there's attention that this could potentially be a problem, but not a ton of guidance in terms of figuring out who really would be the patients that could benefit from triple therapy versus those who are more harmed. So as has been highlighted in the past, we know that triple therapy carries a higher bleeding risk. So here we see a graph that's comparing triple therapy versus a dual antiplatelet, so a P2Y12 plus aspirin, and we see much higher risks of bleeding admissions to the hospital. And here we see, though, on the other side, that there is the potential in all comers, right? So people of various levels of comorbidity, various levels of functional impairment, that triple therapy may have a lower risk of ischemic stroke. In this large study, we see that there is a risk reduction by having the oral anticoagulant on board compared just to dual antiplatelet therapy. But of note, look at the absolute risk reduction. We're looking at an order of 1.5%. So we're thinking about various different risks that are all competing with each other in our older adults. So here we have a meta-analysis, and here what we're seeing is looking at overall cardiac events. And this meta-analysis is suggesting that our overall effect favors triple therapy in terms of reducing the risk of cardiac events versus dual therapy, which is here the comparison group is again dual antiplatelet therapy. Now, and here, another meta-analysis really looking at the exact same issue found opposite results. So as you can see here, the groups are actually reversed in terms of where they're placed on this forest plot. But what we're seeing is a benefit for being on dual antiplatelets versus being on triple therapy. So it's really an open question in terms of what is the magnitude of potential benefit in terms of reducing the risk of recurrent heart attacks and in terms of stroke risk for these patients. And so thinking about this from a geriatric perspective, we know that medically complex older patients have much less been included in drug clinical trials on which most of our clinical guidelines have been based. And they potentially have less benefits that they may obtain from treatments or interventions, and they have increased risk of drug and drug disease interactions. So we know that geriatric conditions affect outcomes in both AMI and AF, but we don't really know for these patients that have both which geriatric conditions could point us in terms of better understanding what the benefits and harms are. The other thing that I think we were sort of wondering and informed by some of my experience in the clinical world was what really was driving some of the prescribing behavior. After seeing Mr. S back in 2013 and through the rest of my internal medicine residency, I've seen various patterns of what different cardiologists and primary care doctors have done with this situation over the last several years. And we were curious in terms of what factors actually predicted whether they would prescribe triple therapy versus other courses of therapy. And then, as I said, we also want to know about the benefits and harms in terms of stroke risk, cardiovascular events, and bleeds.
And do these geriatric conditions, are they influencing the overall effect of these medications?
Okay, thank you, Greg. I think I'll take over from there. Thank you so much for that comprehensive info, and thank you everyone for holding on as we deal with the transfer. So in order to address some of these ambiguities and uncertainties that Dr. Ouellet just walked us through regarding why certain older adults are prescribed antithrombotic regimens over others and what the outcomes associated with those antithrombotic regimens are, the aims of our project was to first characterize the prevalence of triple therapy and alternative antithrombotic regimens among older adults with comorbid AMI and AF, and then we wanted to examine the association with these different antithrombotic therapies with the outcomes of major adverse cardiovascular events and bleeding over a 6-month follow-up period. And then lastly, we wanted to just explore, and in truly exploratory analyses, as you'll see, the potential effect of multiple chronic conditions or multimorbidity and frailty as exemplar geriatric condition moderators of the association between these different types of antithrombotic therapies and our outcomes of MACE and bleeding. And so as Greg mentioned, to accomplish these aims, we had the really good fortune of using a data set called the SILVER-AMI data set, and this is a longitudinal nationwide study that was completed in 2016 and headquartered here at Yale, of which the principal investigator was Servit Chowdhury. And this study enrolled about 3,000 older AMI patients hospitalized at about 100 centers across the United States and captured very rich data on demographic, clinical, and psychosocial characteristics of this cohort. But what really sets the SILVER-AMI study apart from other cohort studies of AMI was that we did a brief but comprehensive geriatric assessment in the hospital that included things such as mobility and multiple chronic conditions, cognition, fall risk, and the constructs of frailty, and we were able to map these geriatric syndromes and conditions onto outcomes in this cardiac population. So for this project specifically, we used the subset of the SILVER-AMI cohort that had comorbid atrial fibrillation. And it just happens to turn out that close to 30% of our cohort did have comorbid atrial fibrillation. So for our first aim, the goal of which was to elucidate factors associated with receipt of different types of antithrombotic therapy, we organized our outcome as receipt of triple therapy versus all the other alternative antithrombotic regimens at hospital discharge after an AMI, so at the time of discharge for AMI hospitalization in the SILVER-AMI cohort. The factors that we wanted to examine to see if they were drivers of receipt of different types of antithrombotic therapy included foremost multimorbidity and frailty, but also things such as baseline stroke and bleeding risk. These are things that have traditionally been known to drive different types of antithrombotic therapy regimens, and indeed what is indicated for clinical decision-making in support tools such as UpToDate. We also examined various demographics, in-hospital procedures such as percutaneous intervention, other geriatric vulnerabilities such as mobility and falls, and lifestyle and psychosocial factors such as smoking and depression. In terms of our analytic approach, we use multivariable adjusted logistic regression of all factors that we found to be associated in bivariate analyses with receipt of antithrombotic therapy at the significance level of P of less than 0.05. And I'll note that we did use multiple imputation to account for missing data. So our overall sample included 832 patients. The mean age of the sample was about 82, and we were just over half male. We struggled a little bit in recruitment of non-white participants, but this is actually on par with demographic characteristics of the older population. The vast majority of our SILVER-AMI subcohort underwent cardiac cath during hospitalization, and that has some implications for whether people are prescribed an antiplatelet at discharge. And about 2/3 of our cohort had AFib documented in their medical record before they came in for the AMI, whereas about 1/3 were diagnosed during their AMI admission. In addition to these characteristics, we looked at, as I mentioned, both multimorbidity and frailty. We looked at multimorbidity using the Charlson score, and we found that the median Charlson score in our cohort was about 3, and about half of our cohort would be considered multimorbid. So many people use a Charlson cutoff of 4 or greater to indicate multimorbidity. And in terms of frailty, we were actually really surprised to find that the vast majority of our cohort were either pre-frail, a little over half, or frail, close to 1/3, and only 15% of our cohort, as assessed, of the frailty items were assessed during hospitalization, only 15% were deemed non-frail. So that was a big surprise to us. When it comes to types of antithrombotic therapies prescribed at discharge, we found that our main group of interest, those on triple therapy, the incidence was about 20%. So you see that red wedge, and that's kind of a group that we focused on in great detail. But what you'll also see by examining this pie chart is that prescription of antithrombotic therapies at discharge, it was sort of like the wild, wild west, or so we think. So there were actually 8 different permutations of antithrombotic therapies applied to these older adults with comorbid AMI and AFib at discharge. And you see that some were really quite prevalent. So we see that dual antiplatelet therapy in blue was quite prevalent in 1/3 of our cohort, whereas there were some antithrombotic regimens that were very rare, and we sort of scratched our head as we started analyzing these data about who are these folks who would be on an antiplatelet agent only or an anticoagulant only, these tiny little slivers. And so for the purposes of the rest of our analyses, because these numbers were so small, for example, there were just a handful of people who were on an antiplatelet and an anticoagulant at the same time, we had to limit our analytic sample to only the top 4 most common groups for analysis. So the good news about this is that even though we had to remove some of these less common groups, we did retain over 90% of our cohort for analysis. So when we examined the drivers of antithrombotic therapy choice among these 4 groups of folks, we found some pretty interesting results. So I just want to orient you that although we were principally interested from the get-go in older adults who received triple therapy, we're actually using the triple therapy group as the comparator group. So you might take a little while to orient to the relative risk ratios and odds ratios that we show in the presentation. So I'll do my best to guide you through that. So for folks who were prescribed aspirin only at discharge, we found generally that these folks had a lower thrombotic risk as evidenced by the CHADS-2 score that Dr. Mentias described, and higher bleeding risk as evidenced by the Hazlitt score that he also described. Funny enough, we did find that education was a driver of aspirin-only use, but we think that this might be collinear with age. And for folks who underwent percutaneous intervention and probably received a stent or 2, they were much, much, much less likely to be on aspirin only than triple therapy. The same story goes for folks on dual antiplatelet therapy. They had lower thrombotic risk and higher bleeding risk than those on triple therapy. We also found, interestingly, and this is counterintuitive to what our resident cardiologist had predicted, that DAPT was less likely over time in our cohort. So the Silver AMI data set was collected from 2013 to 2016. So it's a great, really contemporary cohort, and we did find that triple therapy actually increased year over year, so the incidence of triple therapy prescription. And then for folks who had pre-existing atrial fibrillation, for which the indication for anticoagulation is much, much stronger than folks who have, let's say, new onset AFib as a result of their MI or perhaps as a result of undergoing CABG. So folks on dual antiplatelet therapy were much less likely to have new onset atrial fibrillation. And then for this funny group, they're a clinically funny group of folks on aspirin plus an anticoagulant, they were less likely to, if folks were multimorbid, they were less likely to be in this funny group of aspirin plus anticoagulation. And then once again, we found that education was associated with this more conservative approach, and percutaneous coronary intervention. Again, if you underwent percutaneous coronary intervention, you were very likely to be on an antiplatelet, which meant you were less likely to be on aspirin and anticoagulant alone. So just to point out a few of those things, we mentioned percutaneous coronary intervention, and we did see that the traditional factors associated with clinical decision-making for antithrombotic therapy, these were large drivers of antithrombotic treatment choice, even in our older adults. And what we did see, with the exception of Charleson's score for aspirin and anticoagulation, which left us scratching our heads a little bit, we weren't exactly sure how to interpret that, we found that geriatric conditions were not really associated with antithrombotic treatment choice. So to summarize, we found that it was really baseline risk of thrombosis and bleeding that were the drivers of antithrombotic therapy choice. And if you received a PCI and you got a stent, you were on an antiplatelet. So you were very unlikely to not be on an antiplatelet or in one of those antiplatelet groups. As I mentioned, confusingly, we did find that multimorbidity was associated with lower use of aspirin plus anticoagulant. We think this might be due to the fact that multimorbidity may track with greater risk of cardiac disease. Cardiac disease could be associated with stents, and so you would be less likely to be on a regimen that doesn't have an antiplatelet in it. And frailty was not predictive of therapy choice. So moving on to our second aim, which was the meat of our study, we were really interested in examining the association of these different antithrombotic therapy regimens with MACE and bleeding in this cohort. So once again, our analytic sample consisted of the comorbid AMI and atrial fibrillation patients who were on the four most common antithrombotic regimens. And our outcomes were operationalized as either a major adverse cardiovascular event within 6 months of hospital discharge. And for this MACE definition, we included cardiovascular death, recurrent MI, stroke, or need for emergent revascularization. And our competing outcome was clinically significant bleeding at 6 months, which we defined as any bleeding event that necessitated an ED visit or a hospitalization within 6 months of hospital discharge. And for our analysis, much like what Dr. Mentias and Dr. Sarrazin performed, we also had to account for indication bias in our analysis. So we used inverse probability of treatment weighted logistic regression, and we also used, and it was an interesting exercise to create propensity scores and inverse probability of treatment weights for exposures that have more than 2 groups. So that was a nice exercise for us. And again, we use multiple imputation to account for missing data. So I'm going to show you a number of bar graphs for the rest of our presentation. And the reason I did this is because we did perform interaction analyses and regression analyses, but I feel like the easiest way to convey our results was through bar graphs. So in terms of the incidence of our outcomes, we had relatively low outcome rates, which is not surprising for a short follow-up time of just 6 months. But MACE occurred in 8% of our cohort, and clinically significant bleeding occurred in 12%. So these rates are low, but they're not negligible. And in terms of the association of antithrombotic therapies with our 2 outcomes, we found that overall, more intensive antithrombotic therapy was associated with lower risk of major adverse cardiovascular events. And conversely, more intensive antithrombotic therapy was associated with higher rates of bleeding. There was one exception that we found, that folks on aspirin were really not sort of falling in line. We would hypothesize that folks on aspirin only would have the highest risk of MACE during the follow-up period, but as you can see from that orange bar on the left, that's actually, the dip is a little bit low, so the incidence of MACE is a little bit lower in aspirin only than, let's say, the DAPT cohort. And so we thought, there may be a few reasons for this. One might be that there's a competing risk of death at play. So we did find that the death rate was highest among the aspirin-only group. So these folks might have died or otherwise been incapacitated by an event other than what we used for our definition of MACE. We also thought that there may just be some patients on aspirin only who, while on paper they have AFib and concurrent AMI, their actual severity of both or either of these diseases is not really, all that severe. So you may think that somebody has paroxysmal AFib with a very low burden of actual symptomatic arrhythmias, or somebody might have had a very small MI that might not have warranted cath or PCI, or they had a POBA. So that's what we were thinking. Those could be the two reasons why we see this little downward blip for MACE in aspirin only. So again, I want to orient you to how to interpret these forest plots. So we've used triple therapy as the comparator group, so that you'll see on the left here that participants on antithrombotic regimens other than triple therapy were at no greater risk than the triple therapy group of experiencing a MACE during follow-up. So to put this in another way, there was no benefit of triple therapy on MACE outcomes. And then, whereas there was a higher risk of bleeding among participants on triple therapy, as you see in the forest plot on the right, but conversely, how this forest plot should be read is that there was a lower risk of bleeding among participants on regimens other than triple therapy. So my apologies if this is sort of contorting in your mind a little bit. But the take-home message was that more intensive antithrombotic therapies, they didn't yield any more protection against thrombosis, but they were associated with greater bleeding risk. And then lastly, we wanted to explore the role that multiple chronic conditions and frailty may play as moderators of these associations between antithrombotic therapy and outcomes. So to do this, once again, we used our same analytic sample of 742 patients with AMI and comorbid atrial fibrillation who were on the 4 most common antithrombotic regimens. And our outcomes were the same, MACE and clinically significant bleeding at 6 months. And for this analysis, we used the moderators of frailty status, which we operationalized as a Fried score of greater than or equal to 3, or MCC status, or what I may call, although it's starting to be out of vogue a little bit, multimorbid status, which was operationalized as a Charlson score of greater than or equal to 4. And then for our analyses, we tried a number of different things, but I want to stress that these analyses were really exploratory due to limited power. So as I mentioned previously, the rate of the prevalence of frailty in our cohort was about a third, so 31%, and the rate of multimorbidity was almost half, so 49%. So these two issues were really quite prevalent in this cohort. Funny enough, though, and I know this is sort of repeating from AIM-1, we found literally no signal between between presence of frailty or presence of multimorbidity and likelihood of being prescribed these different antithrombotic regimens, which we just found to be wild. You would think that we would have seen something that, frail folks may be slightly less likely to be on a really intensive antithrombotic regimen. But as you can see, the prevalence of frailty among the different antithrombotic groups and Charlson score greater than 4, they're really quite flat, which we found very interesting. And that really tells us that, even not doing any fancy analyses, just looking at the raw numbers, that these two factors really are not on clinicians' minds when they're thinking about antithrombotic prescribing. So if you'll allow me to apologize. I know that there are a number of colors happening in this presentation. I just wanted to try to use different colors to denote different things. So we're moving away from the antithrombotic therapy choices for a moment, so I'm using different colors. You'll see when you look at just the associations between our geriatric conditions and outcomes, we certainly are seeing signals. So folks who were frail, not surprisingly, were at greater risk of MACE and greater risk of bleeds. And the case was even stronger for multimorbidity in our outcomes. So in bivariate analyses, multimorbid folks were really a lot more likely to experience these events. So when we started to investigate how frailty and multiple chronic conditions impact the relationship between antithrombotic and antithrombotic therapy and outcomes, we found some pretty interesting results. And while we can't really hang our hat on any of these results because our power is quite limited, there's definitely some food for thought here. So, and we would really welcome if there is anybody in the crowd who has different interpretations for our findings. We'd be very happy to hear from you. So in short, statistically, we found no interaction between antithrombotic therapy type and frailty status with regard to MACE, with our MACE outcome. And you can see generally in these graphs that the proportion of participants receiving MACE, let's say if we look at folks on dual antiplatelet therapy who are not frail and frail, we see a little uptick in the rate of MACE among folks who are frail, but they're generally looking pretty similar. And the story is the same for those on aspirin plus anticoagulant and triple therapy. So we concluded here that although folks who are frail are more likely to experience MACE, it's really not driven by their antithrombotic therapy choice, which we found interesting. There is this one exception of the aspirin-only group, which we found funny, and I just wanted to bring you back to our prior finding that we had talked about, this funny finding of relatively lower risk of MACE among aspirin users, and I think an interesting finding of this project is that the frail folks were at increased risk. The frail folks on aspirin were at increased risk of MACE, but not necessarily the non-frail folks. So this sort of supports our hypothesis that there are some folks with comorbid AMI and AFib that are really rather healthy, so they're just prescribed aspirin, or this is at least what we're thinking may be the case. And so they're prescribed aspirin not because they're too frail to handle a more intensive antithrombotic regimen, but maybe just because they don't need it because they're really at low risk. When we looked at the association of multimorbidity and antithrombotic therapy and MACE, we found generally the same story, although I have to say that our numbers here are a little bit more wonky. Some of our numbers were quite small in these analyses. Of interest, we found that among folks who were multimorbid and on triple therapy, none of them experienced a major adverse cardiovascular event. And and you'll see this in that there is no red bar on the right side of the screen. So we found that to be quite interesting. Oh, my apologies. Okay. So, and we double-checked the numbers, and this was actually not this wasn't an infinitesimally small group. There were more than 80 people in this group, so we found that quite interesting. When it came to our bleeding outcomes, we found that generally the same story, that folks who were frail, regardless of antithrombotic therapy type, they were at greater risk of bleeding. And we did find a little blip, a little uptick in bleeding rates among frail folks on aspirin and anticoagulants. So we kind of chalked this up to this is a weird group of aspirin and anticoagulant use in the absence of antiplatelet, and there might be a lot of confounding by indication at play here. And then lastly, when it came to multimorbidity and antithrombotic therapy, we found again that in general, although these are really very exploratory, that patients who were multimorbid were at greater risk of bleeding, but it wasn't necessarily due to their antithrombotic therapy choice. So we did see with more intensive antithrombotic therapy, there was greater risk of bleeding, but it was consistent whether you had a low multimorbid status or a higher multimorbid status. So what can we take away from all of this? So in terms of our first objective, we think that it was really interesting to note that even in this older cohort that is really struggles quite a bit and is burdened by geriatric conditions, geriatric and functional characteristics do not really seem to be very influential in determining antithrombotic therapy choice, and that antithrombotic treatment decisions, they were driven largely by traditional risk factors of thrombosis and bleeding. And for AIM-2, we did find that more intensive antithrombotic therapy treatment increased the risk for bleeding with questionable benefit for thrombosis prevention. And this is actually quite in line with some research that's been done in younger populations and has sort of caused the clinical community to really question the utility of triple antithrombotic therapy and the duration that triple antithrombotic therapy should be used. And this is especially relevant for our older, more vulnerable patients. So when it comes to our takeaways for AIM-3, examining geriatric conditions as moderators, well, we found that frailty and multimorbidity neither were good for these patients, so they were both associated with worse outcomes. They both exacerbated the risk of MACE, more so with less intensive antithrombotic therapy, and they both exacerbated the risk of bleeding, more so with more intensive antithrombotic therapy. So we really conclude that clinicians continue to be left between a rock and a hard place when it comes to antithrombotic prescribing for these older, vulnerable adults, because they're more at risk for both outcomes, and you're damned if you do and you're damned if you don't. So while we would have loved to neatly wrap up, our clinical decision-making with a bow and say, this is what you should be prescribing for your older, vulnerable patients, unfortunately, that can't be the case for us today. So there are a few strengths of our study to note, as well as a few considerations for limitations. A huge strength of this study is that we use a contemporary data set that's really reflective of current antithrombotic therapy prescribing, and that included several data points related to demographics, clinical variables, as well as geriatric conditions. We also rigorously operationalized our variables, including the tried and true characteristics of multimorbidity and frailty that were operationalized by the Freed and Charlson indices, which are, sort of traditional, and they're not always available in large-scale data sets. But we do have a few limitations to talk about. We did have a relatively short follow-up time, which limited our power, and we were also limited in power to explore multimorbidity and frailty as moderators, as mentioned previously. And then in line with Dr. Mentias's work, it's really important to think about, in this age of novel oral anticoagulants, to think about how these different anticoagulant subclasses could be affecting outcomes. So for what we think clinicians can take away from this investigation is, we think as a starting point, providers really should consider geriatric conditions when deliberating about antithrombotic treatment choices among their medically complex older adults. And for future directions, we hope to expand our analyses to larger data sets to allow for sufficient power. And in particular, there's been some recent buzz in the cardiology world about the use of dual antithrombotic therapy. So that would be an antiplatelet agent and an antithrombotic agent, and an anticoagulant. And they're thinking that that might be a really good compromise for maximizing the thrombosis prevention and minimizing bleeding risk. And of course, having a larger data set would also allow us to investigate differences in these outcomes according to anticoagulant subclasses. And lastly, what we think might be a really important next direction is to investigate how clinicians make decisions about antithrombotic prescribing in their medically complex older adults by asking them themselves, and maybe including incorporation of how clinicians use patient preferences and goals of care to guide these treatment decision-making choices. So we'd like to thank our study team, which included several wonderful folks from both Yale and UMass, Dr. Chowdhury and Tinetti from Yale, and Dr. Jerry Gurewitz and Tizmanetsky from UMass. And we will take any questions that you have. Thank you very much.
Thank you so much. Thank you to all of our speakers for their excellent presentations. Now both of the presentations are open for questions that you may have. As a reminder, please click on the Q&A tab on the right side of the screen and type in the Q&A box, and then we'll get your questions and forward them on to the speakers. We do have one question for the first presentation. The question is, do you plan to remeasure your association with creatinine measurements to adjust for chronic kidney disease, which would not be knowledgeable through the Medicare data. Dr. Mentias or Sarrazin, would you like to take that question?
So I can, this is Mary, can you hear me?
Yes.
Yeah, so so that is a good point. You know, one of the drawbacks of the Medicare data is we don't have lab values. We did control for, kidney disease as it can be measured with ICD-9 codes, which does, distinguish severe and moderate renal disease, although there's always questions about, how accurate those are. We are actually working now on a follow-up study related to the use of DOACs, not specifically in patients with multiple chronic conditions, but we are using a data set that does have access to the lab values. And so in this ongoing analysis that we're working on now, yes, we are pulling in GFR actually as a measure of kidney function.
Oh, that's great. There's a similar question about other variables like alcohol and other things not captured well in Medicare. Some idea was mentioned about using MCBS survey data.
That's actually a great idea, the MCBS. We hadn't actually thought about that, but I appreciate that suggestion. That's something we can certainly look into. I don't know, the time frame that we were looking at, these drugs were still kind of, kind of coming onto the market. And so when, if we were to try to pull in the MCBS, I think that would slice our sample size substantially, although it's possible nowadays that these drugs are much more commonly used. We'd still have sufficient patients, but that is a great idea.
So I don't see any other questions right now. If you have a question, please type it into the Q&A box. Heather or Catherine or Chris, do you see questions coming through from your side? Or do the panelists, do you have any questions for each other?
This is Catherine. I'm not seeing any questions come through on my WebEx at this point.
So maybe I have a question for Dr. Hajduk. Could you talk about what was the most difficult thing about conducting your study in terms of challenges and all the great work that you did?
Well, thank you, Leah, for the question. I think we faced a few challenges. I think there's the perennial issue of power. So, we did find that after cleaning our data set, our numbers were a little bit smaller than we had hoped that they would be by about a quarter. So that limited our power. I think the other analytic challenge that was exciting and fun, but also kind of tough to deal with was and I'm sorry if I'm going to get like super nerdy on everybody, but was the application of multinomial propensity scores. So that's a relatively new thing that both Drs. Mentias and Sarrazin and our team did. And we had to do that because we had 4 different exposure groups or 4 different treatment groups to account for, and integrating the propensity scores, or the flip coin of that inverse probability of treatment weighting, with multiply imputed data, it really did turn out that we were running up against sort of the limits of what our statistical analysis could handle and what's out there. So, we have these relatively simple questions that we want to answer, but when it comes to trying to control for confounding by indication and trying to account for missing data to maximize our power, we did end up really facing some formidable analytic challenges. So I will get off of my biostatistical soapbox, but I'd say that was the biggest challenge.
Thank you. We do have a comment for the Yale group. We have a comment from Ala Kapoor, who says, I think an equally interesting question would be continuance of the antithrombotic therapy for 1 year after triple therapy, after which guidelines would say to stop the ASA plus Plavix and continue only AC, but many care providers continue all three.
Yes, that's a really great insight, and I know that my colleague Greg, who is our geriatrician and clinician, had to jump off the call. But I'll do my best to address this comment. It does appear that although we only have 6-month data, when you look at the guidelines and you try to think about the duration of antithrombotic therapy, whether it's aspirin and Plavix or anticoagulant, the duration of therapy, the guidelines appear to be all over the place, as Dr. Ouellet hinted at in his slides, but it really gets more complex as you look into it deeper. And I do think it would be super interesting to see whether physicians really do a good job of saying, okay, you've been on this drug, that was indicated for a year, let's get you off of it, or is there just this clinical inertia that causes people to just stay on until, hopefully, and by the grace of God, somebody, a geriatrician comes by and does a good med rec and says, maybe this patient doesn't need to be on all these antithrombotics anymore. So it's a very interesting question, and I think the jury is certainly out on how long these folks should be on these meds and what the effects are of discontinuing. And just to put in a little plug, there was a study that came out recently, I think it was in the American Journal of Cardiology, that found that discontinuation of an anticoagulant was associated even in past the 1-year indication mark was associated with worse outcomes. So I think it remains to be seen what the optimal duration is.
Well, thank you for your response. Do we have any other questions? Last call for questions. Type them into your Q&A box. Well, I just want to thank you again to all of our speakers for their presentations and for everyone for attending today's webinar. The recording for this webinar will be posted soon on the Aging Initiative website, which will be linked in the chat below. As you sign off, you'll be prompted to complete a very brief survey. We'd appreciate you taking the time to give us your thoughts or opinions you had about today's webinar. I want to thank everyone again and have a great rest of your day.